So we've got a scenario here where we've got issues with tooth number 19. We're going to be cutting off the crown and taking out the remaining tooth root, and then we're going to evaluate the bone and soft tissue to make sure that we can do an immediate implant. Based on our pre-diagnosis, we should be able to accomplish this. But as you know, sometimes things aren't always the same as what you think they are, but it appears that we should be able to do that rather straightforward. So we're just cutting the crown in half so we can then have access to removing the roots out one at a time. We're going to section the tooth in two. You can see here that we've already started part of that with our initial cutting off of the crown. So now we're going to go ahead and section right between those two roots. See here, got a rather, we can see here how we lost the anterior portion of the buildup. Go through, make sure we hit that lingual wall. That's fantastic. Now what we want to do is we just want to make sure we have bleeding all the way up and down there to make sure we've gotten all the way through the tooth, and it appears as though we have. See if we can't just get a little bit of separation between the bone and the tooth itself. And this is the patient's game here. Brian, you're just feeling pressure, correct? Mm-hmm. All right, buddy. That's all you should feel here. It's just a little bit of pressure. Just kind of push it a couple of different directions. And then I'm going to come from the mesial and push this mesial root into the space we just created. Yes, please. And again, we're just kind of letting nature take its course. As you know, as we start putting the pressure between the two roots, we're starting to get a blood clot that will help start pushing tooth out itself. So theoretically that should help take the tooth out. Bless you. Force it. Thank you. Alright, there's going to be a little bit of pressure here now. Now I'm just going to put some rotational forces on this. Again, just be nice and patient. That's the best thing you can do, is be nice and patient. Where the decay is, so not much tooth left above the. So now we'll go ahead and come to the mesial root. Try to do the same. Boom, boom. All right, distal root. See if that won't help us in line. All right. Inside, maybe we can move this distal root to the distal a little bit. Have the straight periotome, please. And we can see here now how we've got basic movement of just the tooth, because the decay is just giving instead of. So that's normal. That happens all the time. This is my little chopstick technique, if you will, where we now come in from the distal and the mesial, and we just put pressure from one to the next slightly. Yep. Give me this half round, please. That's too bent. Thank you. Hopefully, slowly but surely, we can get these roots to see way it coming out more than not. But by doing things like this, this allows us to help protect the soft tissue, and ultimately then that precious buccal bone. That's really key in doing something like this. Yep. And again, we're going to see if we can't put some rotational forces on these roots here. And if we can, fantastic. If not, well, then we need to figure out, can we just then section a tooth into multiple pieces. There's not much sense in, if you got an ankylosed root, sitting and waiting. Yeah. Yep. His head is slightly to the right, Destin. Do you need me to, okay. A lot of water in there, Brian. You're doing great, buddy. All right, so we're just going to hopefully start seeing some of these pieces start coming out. Basically what we're doing is a reverse crossword puzzle, or a reverse puzzle here, if you will, where we're just trying to get different pieces out at different times and preserve the bone and preserve the soft tissue. That's the ultimate goal if you're going to do an immediate. It just becomes, you have your goals, right? You got to make sure you have your goals, and if the goal is to get an immediate implant in, you got to take the roots out as you see fit, and sometimes it's hard. Sometimes the roots are ankylosed and you just don't know what to do. Well, this is what you do. You don't sit and fuddle putz around. You gotta get in there and make sure you get out part of the root, and then keep pushing those little pieces into the space that you've created, because that ultimately is what's going on here as we're creating that reverse puzzle, if you will. Half round. Again, you can just see how the tooth is just that brittle. Do it, but she said never mind. Alright. Again, here we're just trying to get a pull back with that suction a little. Can't see past the tip. Lots of water in there, Brian, I know, buddy. There we go. That's what we're talking about. Needle nose. Alright, beautiful. Alright, well, straight periotome. So I've just done a distal root. It's just where there probably was a fracture down in the root, and it just has nothing that wants to let go. Again, I'm just trying to do everything I can to keep that stress off the buccal plate, because that's, yep, thank you. There's just a teeny little piece of tooth root left here. That is now going towards the lingual, which is awesome. Just got to be real careful. And we're just kind of using that distal bone now to help give us some leverage. And then we should be able to get in here and somehow wiggle that little bad boy out of there. Needle nose. But that's exactly what's going on here, is we just have an ankylosed tooth. So, God willing, that little boy will just kind of slide right on out. That's the beauty of these needle noses. You can kind of get down a little bit further on something that's been broken off already. Suction, please. There we go. Grit. At least I think I got most of that. There might be a... Now, the first thing you want to do when you get the tooth out is just verify that your buccal plate is still intact. So we've got buccal plate intact all the way up. We just have about 2 millimeters of soft tissue, which is wonderful. So now we're going to look at what's going on internally, and then we're going to start looking at our CBCT to see what the angle of the jawbone is. We always have to worry about, especially in the molar area, the mylohyoid undercut area. And that's really, really important that when we're doing immediates that we stay away from the infraalveolar nerve, but also we stay away from that space. So one of the things I'm doing right now is just kind of making sure we're limiting any kind of bacterial contamination that there potentially could be down here, but also, you know, there's teeny little bits of gutta percha that might have extruded from the apex of the root. So I'm gonna go back to my CBCT right now and evaluate it. Thank you. And here's our buccal lingual bone, anterior and posterior teeth, right? That's all parallel with one another. Now all I gotta do is come get right down the center of this tooth. That looks pretty good right there, doesn't it? Mm-hmm. So now we're gonna be a little vibration here, pal. This is gonna vibrate all over the place. Okay, we just gotta hold steady until we finally get something that allows us to get right down the middle, which is what we're doing right now. Knowing that this working length up to here is 13 millimeters. Alright, so now we'll be right on this. That look pretty good?
Take the top of the handpiece slightly to the distal.
Distal?
Yeah, that's good.
Okay, great. Now, still good?
Yep, good.
Yep. Yep, it's not good. Better?
Good.
Yeah. Sometimes the hard part about these little guys is they have a hard time just because of how big they are. They have a hard time. And one thing we're going to make sure we're doing is staying off of that buccal plate. Alright. We need a 7-9, please. Long, but I'm not sure exactly what our... We have the 8-9. So this is what the implant will look like with threads. Okay. Now let's take, that's an 8-9, correct?
Correct.
So we're gonna go ahead and take a quick X-ray here. You're doing perfectly, my friend. Everything's going really, really well. So we're gonna just get a quick X-ray, just verify where we are up and down. Okay. All right. I want you to close gently on my thumb there. There you go. Right. Yep. Don't purse your lips. Just close gently on my thumb. Right there. There you go. Good. Okay. I think that I want to stick with that 8/9. A small little 1/2 millimeter polished collar there. Okay. All right. So the thing is, when we seat this, we're going to be obviously going down into a cavern, right? So we want this to be over 35 Newton centimeters, and we're already at almost at 45. And we want this to be a couple of millimeters subcrestal. So we're going to take this off now. See where we're at. Just put this really, really good. Really, really good. All right, wonderful. Place our cover screw on here, and we're going to fill in our gap between the bone and the implant. Beautiful. And we're going to, so we've got some Dynacore here. We're going to fill in the gaps here. There's always, in an immediate extraction case, there's always a gap between your bone and the titanium. And so that's what we need to do is basically mud those in, if you will, and that just helps prevent soft tissue from vaginating in there. Blot, please. All right. Mm-hmm. Haven't even gotten to the mesial yet, so you're probably going to have to get some more bone. Unless you have more bone out, and I'm just hearing things. All right. Okay. Blot. Okay. Yep. Right here on the distal still. Other way. All right, that filled in the distal really nicely. Now we're gonna fill in the mesial. I'm basically using just a periosteal elevator, number 14, to help pack our bone in there. All right. Can you turn to your right just a little more? Thank you. So now, again, there's really no gap on the lingual and no gap on the buccal. Except there might be a teeny gap on the buccal. But this really is going to fill in nicely for us. Flat. Yep, right here on the medial buccal. What's the one? Beautiful. A little bit too much there on that tissue portion. All right, hex driver. Need a 3, please. And then we're going to put a healing abutment.
3 or 5?
3. Through a PRF plug. So here's our healing abutment. And then we've got our PRF membrane then that is going to seal this off for us. And then this then basically goes just a little bit subgingival to help keep the body from putting any pressure on it. And then this is tightened as tight as you can get it. All right. Now, let me see that Woodson 1, please. And I usually put sutures in, but literally I'm not going to this time because this PRF membrane has literally sealed everything off for us. Sometimes there's other areas that you need to kind of suture up, but the soft tissue was really healthy. The healing abutment really closed things off for us, and we just need to let him heal. So we're going to go ahead and we'll get a post-op x-ray and see what things look like. Everything looks absolutely beautiful. Healing abutment seated, so that's one of the reasons why you want to take other than just an x-ray to check your placement, but you got to make sure anytime you put 2 pieces together, you take a post-op x-ray to make sure everything's coming together, because every now and then you'll get bone that will prevent your healing abutment from seating. So thank you so much for joining us here at the Midwest Implant Institute, and if we can do anything for you and in regards to your training, please don't hesitate to call or email us or let us know how we can help you.